If committee members have questions for Dr. Miller, we can start with those. So if anyone has questions, please put up your tent and I'll call on you. Nadine?
Good morning. Thank you very much. Those were both excellent presentations. And I had a question for Dr. Miller in terms of, as we are beginning to see more and more data about biomarkers of early adversity and impacts on later life health, cardio metabolic risk, etc. Dr. Miller, in your work, do you see whereas any of these biomarkers present potential therapeutic targets for biomedical intervention? And to what extent are you familiar with research that's happening in that arena in terms of moving in addition to programs that support what we know is very necessary in terms of relationships and buffering and connection. In addition, to what extent do you see this is being targeted to other therapeutics or biomedical intervention?
That's a good question and a tough one to answer. I think that to make a dent in health disparities, we're going to have to do work in the clinic and we're going to have to do work in the community. I think that everybody in the room there understands intuitively that there are structural forces operating through neighborhoods, operating through families, operating through individuals to act on biology to promote bad health, and that intervening at any one of those levels is not going to be sufficient. I work with a lot of pediatricians, and that's a common question: is what can we do? The bad actors here are things that everybody knows. They're, obesity, high blood pressure, glucose intolerance. So I think there's certainly room for a clinic approach to treating some of this stuff in a primary or secondary prevention manner. And I think that's going to make a dent to the extent that we can, improve access of kids to healthcare, and we can focus on those things in the clinic setting. But I don't think that that's all we need to do. I think the upstream forces are strong. And treatments for a lot of these things, have variable efficacy. We're still not very good, despite decades of work, at helping kids and adults maintain weight loss, for example. And that's probably the single most important thing that, in our data come out as key. So I'm not sure I have a specific good answer for your question other than some generalizations here.
Jim?
Thanks so much for that presentation. So, right now, as we think about measures of success, we're talking about relatively broad ones like, vocabulary at age 3, school readiness at age 5, literacy at age 8. So I'm just sort of wondering whether you think we're anywhere close to prime time for starting to use some of the metabolic syndrome or measures of inflammation or other things on a more systematic way, and to move away from some of those other measures, or maybe to not move away, but to enhance their utility. Are we anywhere near there? Should we be doing that? Should pediatricians, for example, be screening for inflammation?
It's a good question. I think it is important to keep in mind that the health side of this story is very new relative to the academic and psychosocial side of the story. That, this is work that's only been going on for at most a decade in any serious way. And most of that work has been on adults looking backwards into childhood. So, there's just not a ton of great developmental data yet upon which you could develop benchmarks to use. I think that's coming, but I don't think we're there yet. There is renewed focus not only in sort of academic settings, but in pediatric settings, and certainly the American Heart Association is making a hard right turn in this direction very much emphasizing childhood cardiovascular risks and premortal prevention. I don't think we yet have strong enough data to say what those cutoffs would look like, but I think it's coming. I guess the other thing I would add to that, and I'm not sure you were implying this, I don't think you were, but I think one of the things that our findings and other people's findings on the cost of mobility, if you want to call it that, is that we shouldn't assume, like we have previously, that academic success and economic success and psychosocial well-being are going to go the same way as physical health. Then in some kids they do, and in some kids they may very well go in opposite directions. So we need to take a more holistic approach and allow for these things to diverge and understand that they may diverge for very good reasons. They may be goals that are just inconsonant with each other for some groups of kids because of the context they find themselves in.
Thanks. So I have Sunia, Natalie, and Ebony, and then just wanted to also remind people that we can go ahead and open up questions to both of our speakers, and we'll probably have about 10 more minutes for this question and answer period. We're getting several questions also coming in on the webinar, and just wanted to let people know if we don't have time to cover those questions today, that staff will ensure that those questions get posed to our speakers and that the information gets provided back to the committee. So, Sonia?
Yeah, hi, Greg. That was great. Sonia Luther here. Also a question about different outcomes. I seem to remember a study, perhaps in the last year, that your team had put out showing that African American boys of higher socioeconomic status were at greater risk for both substance use and depression as compared to lower socioeconomic African American boys. I'm not sure if I'm getting this completely correct, but my recollection is that the interpretations offered were that these are youngsters who are in more integrated settings, racially and ethnically, and therefore are more vulnerable to discrimination. A, am I remembering this correctly? And B, if I am, are there any implications or suggestions for how we might put into place any prevention at early stages for kids such as these?
Yeah, that's a great insight. What we seem to be finding is, as this is a 15 to 20 year follow-up, what we're seeing is that the sort of secular trends for substance use for white kids are such that when they hit their mid-20s and start to get to the beginning of the early adult phase where they're getting stable jobs and having families, that their substance abuse declines quite markedly. That's less true for the Black youth in our studies. They actually have relatively low levels of substance use through childhood and adolescence, much lower than their white peers do. But in their early 20s, it starts to accelerate. And that's the finding that I think you're referring to, that we find a consistent and troubling pattern that, at least for the rural Black youth that we study, they find themselves entering young adulthood, facing limited opportunities in the small towns they live in for satisfying jobs that offer opportunities for advancement and promotion and good lives, and they're finding their struggles finding positive family relationships, and that those developmental challenges of moving into what would be considered a normative early adult period are associated with an escalation of use. So it suggests, a somewhat different life course approach than I think we've traditionally thought about in the SRCD and pediatrics world. It requires thinking about different risk factors and different risk outcomes and different interventions at really different stages. I know that, this transition from, say, late adolescence to early adulthood is quite understudied. Nobody quite owns that. And, at least our work, and I think some other studies are suggesting the same thing, that this may be a period where we really need to think deeply about how to intervene in ways that haven't really been conceptualized yet.
Great. Thanks, Natalie.
Hi. Thank you, Dr. Miller, for a great presentation. My question has to do with clarity related to the age span for our statement of tasks. So we are focused on this prenatal to age 8 period, and I am curious whether or not you think a lot of the outcomes that you presented to us were measured in individuals in adolescence, and I would want to know if you would suggest thinking about that same set for the 0 to age 8 when thinking about the biological embedding of stress, or if there's anything that you would add or think isn't relevant.
It's a good question, Natalie. There's not been much work 0 to 8 on cardiometabolic risks. The work that is out there is the best work is probably the Young Finns data, which is a longitudinal study from Finland. From a cardiometabolic perspective, my read of their data is that until kids hit 12, 13, 14 years old, the biomarker data aren't especially prognostic of long-term risk. They find that lipids and other biomarkers of risk at age 12 or 13 forecast midlife atherosclerosis independent of concurrent risk, but that those biomarkers at age 3, 5, 7 do not. So my hunch based on those data, and they're really the only ones I've seen out there, are that we're not going to get a ton out of earlier screenings. But I think that remains to be seen. Those are old data. There's certainly a different cultural context. There aren't the kinds of disparities in Finland, at least in today's world, that there are in the United States. So I don't really have a great answer in terms of the cardiometabolic stuff. I think that the other thing you may be referring to or thinking about is, gestational interventions, looking at effects of prenatal social environment. Again, there's some provocative evidence there. Thinking of Genetikovic's work on group-based prenatal care in terms of reducing rates of preterm birth and growth restriction in high-risk pregnancies from teenagers. I find that work pretty compelling. There hasn't been a ton of developmental follow-up to see what happens. But I don't know of anything that persuades me right now that we should go after that 0 to 8 period. If there is, by all means, I want to know about it, so send it to me.
Thank you.
Great. I have Ebony, Nadine, Michael, Jim, and Bill, and then I'm guessing we'll probably have to cut it off after that. And certainly I think our speakers will be willing to field questions after this meeting as well if there's additionals.
So Dr. Duncan, you closed by giving us 3 examples of kind of how to get the most bang for your buck when you have limited resources in terms of the universal screening, sliding scale, or universalism. Do you have a sense of, which of those would be the most effective strategy, or would it be kind of on a case-by-case basis?
Yeah, I think it's got to be on a case-by-case basis because the sliding scale just isn't going to work for a lot of services, right? You don't always have these opportunities with the child allowance dovetailing with the child tax credit to fill in a little portion of it so neatly. So it really, it's going to be a lot of clever thinking about, for a particular situation, is it possible to set up an effective universal screening that will get us the small subset of people that we need? Is it possible to think of a sliding scale? Most services we don't charge for, right? So it's got to be on a case-by-case basis.
Great. Nadine?
Yes, Dr. Duncan, in terms of when we look at the healthcare expenditures and the ROI for those expenditures, when we're looking at children, how is the childhood antecedents of life course disease? We were just talking about cardiometabolic risk as a good one, right? Understanding, for example, and as we know with, for example, the adverse childhood experiences research that shows that if an individual has for more adverse childhood experiences, their risk of ischemic heart disease, right? Number one killer in America, one of the biggest drivers of healthcare costs, is more than double. Are the numbers that we're looking at in terms of the impact of investments in childhood inclusive of the long-term costs of the childhood antecedents of lifelong disease?
Great question, and I think the answer is no. Typically, they're not. We just don't have those kind of data. It's if you think about the early childhood education literature, Perry Preschool and Head Start and things like that, Perry Preschool didn't start paying for itself until late adolescence, early adulthood, right? Until it was an expensive program. There were some advantages for test scores, some advantages for reduced special education placements, and being held back. Those can be pretty costly. But it really wasn't until you started seeing the crime differences and the earnings differences that. So unfortunately, the kind of short-run picture and longer-run picture can be quite different.
So from that standpoint, because the focus of this committee is on childhood stressors and the impact over the life course, one of the big questions looking at, for example, the Perry Preschool and the Abecedarian data, and later on they looked at some health outcomes for individuals in their long-term follow-up. And of course, the thing that we notice is that the longer you go out, the greater the cost benefit, right? Are you familiar, or could you share with the committee, if you are, any data about the importance of the intergenerational cost effect? For example, for individuals who receive high quality care or programming, right? Whether or not that has an impact on the timing of generations, and whether or not it has any impact on, for example, the health and well-being of the next generation.
Yeah, I know of one very nice study, but it's a Danish study. So who knows whether the Denmark experience will generalize. But it took advantage of the fact that a nurse visitation program was rolled out across communities in the 1930s and 1940s, and an early education program was rolled out across communities in the 40s and 50s, I think. And the Danes have all these administrative data systems that are very wonderful. I'll send the committee the reference. I think it's published. Do you know, Elizabeth, what? Yeah. Anyway, it found big effects on lifetime earnings and, I believe, health for kids who were exposed to the either program. What was interesting, it was the study was focused on the combination of the program. Do you get more than twice the bang for the buck? And it turns out having the second program adds almost nothing to the benefits of the first program. But it also, those took place so long ago that you have information about the kids of these people who were in these programs. And there were some, it was more selective, but there were some benefits that were showing up in the second generation as well. So I can send you that. I do caution people use Abecedarian and Perry to justify all sorts of expenditures. They were very intensive programs. They were run by researchers. And what I worry about most is that they were operating where the control group was exposed to much more deprived conditions than today's control groups are exposed to, right? So if you think back to the 60s, moms had 8 years of education, now it's 12. Low-income moms were much less likely to work. There was much less alternative care available. Family sizes were typically 5 siblings instead of 1 or 2 siblings. So all of the demographic changes and policy changes have enriched the environments of the counterfactual conditions. And, there have been some long-term studies of Head Start effectiveness that seem to show big payoffs into adulthood. But if you look at the National Head Start study that was done about 15 years ago, nice, big, random assignment study, representative sample of Head Start centers. By first grade, there were no differences in achievement, either literacy or math. There were no differences in socio-emotional behavior. There were no differences in parenting. So it's hard to know what the active ingredients might be for long-term differences to show up. They might show up. It might be some sort of magical sleeper effect. But at least with Perry and Abecedarian, if you look at the data closely, not only were there advantages in adulthood, but there were advantages all the way along the line. In Perry, the IQ effects disappeared, but achievement effects persisted. There were socio-emotional advantages. So I just don't know to what extent you can comfortably generalize from the old experiments that had very different counterfactual conditions to policies that we might put in place now.
Thanks. We have Michael, Jim, and Bill.
Hey, Greg. So in terms of the child allowance, would you have it work through the tax system? And if so, those who have tax liability less than $2,000 would just get a refund? And then would you put a cap on that, or would billionaires be getting the $2,000 child allowance?
Well, in the Russell Sage Journal article, we would just eliminate the child tax credit and the additional child tax credit. We've already eliminated the child exemption. Just get rid of it and put in place, administered by the Social Security Administration. They're really good at sending out monthly checks, right? So IRS tells them what families are eligible, and it would be a monthly check sent to everyone, maybe with an upper income limit, depending on whether you wanted to impose that or not. So it would be totally divorced from the tax system, apart from the fact that the IRS can best keep track of which kids are living with which families.
Jim?
Greg, thank you for the great protection. I want to deal with the unambitious question a little bit, and Gene Sterley's data, which are consistently showing the growth of expenditures for elderly populations and the sort of squeezing out of the kids. But sort of wondering what the real political will is here. So we have seen some substantial changes in allocations of expenditures by the federal government over the last year or two. I mean, radical changes, quite dramatic. Obviously, a political will that led to those changes. What are the realisms of political will that might affect percentage for kids?
Well, the radical changes came with a $1.5 trillion deficit, right, over the next 10 years. So it's a lot easier.
Very radical.
Yeah, it's a lot easier to do that. Maybe you're more optimistic than I am. Maybe we'll hear from the states, and the states tell us they've got all sorts of money, and not the Social Security burdens that the federal government faces. We can all try to prognosticate on what the politics are going to be, but they've been consistently toward work requirements. It's never. One thing that's been a great source of frustration, back to the welfare reform debates, kids were never part of those debates, right? It was always about whether the mom was working or not. And 5 years ago, it was all about whether adults were going to be spending time in their hammocks, right? It was just this obsession with adult work behavior, and it was never about the extent to which changing benefit levels and eligibility might affect kids, right? So you may know we've got this random assignment experiment going, recruiting moms at birth, and we're really trying to nail down what the causal effect of income is. But until we have that kind of evidence, I think it's really hard to inject kids into debates about economic support. Just the numbers. There's a strong political will to increase defense spending, to not increase the total size of government, to not cut Social Security benefits or Medicare. I just don't see any logical way in which kids are going to come out okay with that.
So we have time for one more question from Bill.
Thanks. I really enjoyed the presentation. I guess my question is around really some of the same stuff we've been poking at, which is this idea of cost effectiveness or effect size per dollar invested or things like that. And I think we see a lot of folks who tend to try to make those numbers work by going long, like over some period of time, this is all going to magically pay for itself over 1,000 years or whatever. So what I don't see a lot of, as much of, and maybe you could talk to us a little bit about what's happening in this area, is going broader. So thinking about the interconnectedness of impacts, even in the shorter term, where the same families who are hitting my EDs are probably the families that are the schools are struggling with chronic absenteeism in. They may be families that are receiving housing or other social services. And so the idea that a program or an intervention that impacts one of those dimensions may have ripple effects that create value, so to speak, in a broader sense across the total community. And when you start thinking about the sort of value case for interventions, we tend to think of them in a pretty siloed way. I'm wondering if there's some work out there around sort of modeling the interconnectedness of impacts across sectors and then doing valuation based around that sort of rippling interconnected effects.
Great question. Not much work. The Promise Neighborhood Initiative was really an attempt to scale up Harlem Children's Zone, and that was kind of a community approach. But to my knowledge, it wasn't done in a way where we've got really solid evaluation evidence coming out of it. I think in the developing world, some of the cash experiments have looked not only at individual outcomes, but also community kind of outcomes. The deworming experiments are kind of a classic example of spillovers potentially showing up. There is an literature on public health campaigns, which is kind of a macro approach as well. But the heart of your question is really, all these individual programs, and does their interconnection add up to more than the sum of the parts? I really can't give you a good citation for that.
Thank you so much, Professor Duncan and Professor Miller, for joining us and giving us these enlightening presentations and answering our questions. As I mentioned, we do have some questions that are coming in on the webinar, and so staff will be sure to get those questions to our speakers and be sure that information gets fed back into the committee's process. So thank you again so much.